Good afternoon, everyone, and welcome to today's webinar, which is titled Community Training on Depression and Dementia. I'd like to make a few notes about our sponsors and funders before we get started. Today's webinar is sponsored by Commonwealth Retirement Advisors here in Richmond, Virginia, and we would like to thank them for their ongoing sponsorship. And this webinar is supported in part by a grant from the Virginia Center on Aging's Geriatric Training and Education Initiative. I'd like to certainly thank our presenters for being with us today. First, we have Tracy Gendron, who's an assistant professor in VCU's Department of Gerontology, and Dr. Andrew Heck, who is clinical director at Piedmont Geriatric Hospital. I'd particularly like to thank them for turning this into a webinar. The funding that they received to do this training was initially started as a face-to-face training that they've been doing across the state, and they have trained nearly 200 people. And then if we add today's numbers to that, we're going to have really a record number of folks trained from this funding, so that's great return on investment, obviously. So because this started out as a face-to-face training, if there are folks on our call who would like to follow up with them individually after the fact, because you're interested in doing a face-to-face training in your community, please contact Tracy Gendron directly about that, and you will have an opportunity to access their contact information at the end of the session. I know we're all eager to hear what they have to say, so I'll direct you to the presenter bios that are on the website if you'd like additional information about that. Of course, none of this would be possible without Nico Stankulescu, who is our platform guru with World Events Forum, and she makes all of this possible. So I want to thank her, of course, for making this work behind the scenes. And I am Ann Welliford. I'm your moderator, and I'm the chair of VCU's Department of Gerontology. Just a couple more housekeeping items before we get started. Like I said, this is funded by the Virginia Center on Aging's GTE grant, and for that reason, we request that you will complete the demographic data survey after the webinar is completed. This, again, is a requirement of our funders, but it also helps us plan for future topics. I know that people have posted some questions that they have, and you know, sometimes you don't get to cover everything that people have questions about, but we do take those questions seriously and the feedback that you provide in planning our future topics. So please take an opportunity to complete that survey at the following of the session. And this is also your opportunity to request a certificate of attendance. So if you would like to have a certificate of attendance, please take the opportunity to do that. You will have an opportunity to post questions throughout the session that we will cover in the question and answer session. And again, we do have a record number of attendees today, so if we don't get to your question, hopefully you'll have an opportunity to follow up offline, or we may use your question for planning future topics. Okay, without further ado, that is the end of my housekeeping, and I am going to turn this over to Tracy and Andrew. Thank you for being here.
Okay. Thank you, Dr. Welliford. This is Tracy Gendron, and I welcome you all. So glad that you could all be with us today. There we go. Get my slide up. So welcome. Thank you so much for joining us to talk about this very important topic of the differentiation between depression and dementia. We're looking forward to spending a little bit of time with you to get into some depth about comparing and contrasting some of the symptoms and behaviors that go along with each of them, in hopes that you will continue to pass this information along to others, including your staff members that may work with you or for you. Although depression and dementia are two different processes, the symptoms and the behaviors that present with each of them can look very similar, they can often overlap, and they can really very easily be confused. This can be complicated by confusing information that comes from the older adult themselves when you're working with them, or from one of their family members when you're having a conversation with them. It can be confused by the type of dementia that the individual may have, the stage of the disease. Perhaps it could be the degree of cognitive capacity that they have, and of course what we're focusing on today, staff knowledge about how dementia and depression present, how they can be very different, and yet in ways how they can be very similar. Now, misdiagnosis of depression as dementia and dementia as depression are both very problematic. but specifically when we misdiagnose depression, we miss an opportunity because depression is very treatable with the right approach. So misdiagnosing or assuming that somebody has dementia can not only extend the period of time before they receive treatment, but even worse, it can prevent someone from ever getting appropriate treatment. And that's obviously a real shame and not acceptable for that to happen. So I want to illustrate an example by talking about a case study. And I'm going to tell you a little bit about George. And George's story is a true story. So I'm going to tell you about him. George was a 70-year-old man, and he was in reasonably good physical health. He lived with his wife of about 45 years in a small country house. He was long retired from his job, and as you can see, he liked to tinker in his shop, working with his tools, and he really liked target shooting. He had a very large, extensive, and meticulously maintained rifle and handgun collection, and he was very proud of this. This was a lifelong hobby of his. What happened was that George's wife started to notice that he'd recently started experiencing some memory problems, and she started to get pretty concerned, especially given that they had both watched George's sister suffer through a very long and drawn-out course of Alzheimer's disease a few years before. And the decline that she experienced was something that was very challenging for them to witness and for them to go through. So when he started to experience the memory problems, they took him to the doctor, a primary care doctor. And the primary care doctor gave, the standard 20-minute interview and exam, and the doctor indeed diagnosed George as having Alzheimer's disease. So clearly they were pretty devastated, and George and his wife then started to plan and anticipate his decline. So George's memory got worse over the next several months, and that eventually required his admission a few months later to a local nursing facility. His wife was relatively frail herself and knew that she wouldn't be able to take care of George as well as herself. But they had an unusual kind of circumstance where the doctor would give temporary approval for George to spend a couple of days at a time on the weekends at home with his wife. So before coming home, the son and the grandsons decided that they would remove all of the ammunition from the house, but they purposefully left his guns because they knew how meaningful they were to George, that they were a part of his personality, a part of who he was, and that this would be something that would be meaningful for him. So instead, they just removed the ammunition to make sure that nothing unsafe would happen. So one day, when they were both at home, George's wife was in the kitchen, and she was preparing a meal, and she heard the shed door slam very loudly, unusually loudly outside. So she went out to the shed and discovered that the sound that she heard was actually not a door slamming, but it was a gunshot, and George had shot and killed himself. In the note that George left, he stated that he didn't want to subject everyone to a very long and very slow decline that he had witnessed with his sister. He was very much afraid of becoming a burden to his family, so he decided to end his own life. He also added that he knew that the family would come for his ammunition, so he hid one bullet for himself in case he ever needed it. So let's think about George, and let's think about this case for just a moment. And I'm going to pose some questions, obviously, for you just to think about. But in your opinion, did it appear that Alzheimer's, the diagnosis, was very carefully considered? Do you think that it was made after ruling out all other potential causes of memory problems? Do you think that we can do that in 20 minutes? Do you think that it's typical for memory problems to appear very suddenly in Alzheimer's disease? And do you think that they progress rapidly enough that George would have to be admitted to a nursing home just within a few short months, especially given that George was in his 70s? Would you typically expect someone with Alzheimer's disease to be able to plan ahead well enough to hide a bullet from their family members, knowing that they were going to come and take the ammunition away, and then even more so than that, more relevant than that, to find that bullet after hiding it after an extended period of time? So do we think that it's possible that George was experiencing either another condition or in addition to Alzheimer's disease, that depression could have been comorbid with Alzheimer's disease? So we don't really have the answers to this. As I said, this is a true story, and we will never really be sure, but it certainly does seem possible that a misdiagnosis may have occurred in this case. And this really illustrates why it is so important for each and every one of us that are working with older adults to talk about this topic and to be aware of the nuances and the subtle differences. So let's talk about some really quick facts about both depression and dementia. A major depressive disorder affects about 1 to 2% of older adults within the community, which is generally lower than the 2 to 3% that we see for younger adults. Significant depressive symptoms affect up to 20% of older adults. So let's note for a moment the difference between the symptoms and the disorder. The disorder is referring to the individual that is classified as having a depression according to a diagnostic standard. Depressive symptoms, on the other hand, affect more people who either go undetected, who don't seek treatment or care, or whose symptoms don't fit that standard diagnostic protocol. And we're going to talk about those differences a little bit more later on. Dementia affects about 5% of people 65 plus and jumps to about 40% of people over age of 85. Clearly, one of the biggest risk factors of development of dementia is age. Now, I wanted to take a moment to share some of our own research with you about staff knowledge when it comes to depression, dementia, and the differentiation between the two. As Dr. Welliford mentioned, we've offered this training session at 4 locations throughout the state of Virginia about 10 different times, and we conducted a study of about 160 staff members who work in long-term care that attended these sessions, and we asked them similar questions to the ones that were posed to you all before you registered for this webinar about their knowledge about depression, dementia, and the differentiation of symptoms. And what we found was really interesting. We found that the type of job that somebody has within the long-term care industry influence their knowledge about depression and their knowledge about the differentiation of symptoms. Specifically, we grouped folks into paraprofessionals or direct care staff, and then professionals are people like administrators, social workers, mental health professionals, and looked at the differences between those groups and found that the direct care staff scored lower on depression and the differentiation knowledge than professional staff did. But what was interesting is that the difference didn't have anything to do with level of education, and there was a variety of levels of education within both of these different groups of the types of jobs. So it seems to me that there's an opportunity that presents itself here for a need for more on-the-job training, something that we can think about, something that we can do, and part of the reason why this presentation was developed in the first place was to go do some on-the-job training for all levels of staff. What else that emerged from this was that neither job or education influenced knowledge of dementia. There's more good news there. To me, that means that we're doing a really great job providing education and training on dementia, and that all the effort that we're putting through is certainly coming forth for all levels of staff. So not only were there no differences between these groups, but the overall level of dementia knowledge was very high. Another question or series of questions that we asked folks was about their perception, whether they felt or what percentage they felt of folks that were both in their facilities and in all long-term care facilities had depression and had dementia. And this was also very interesting and very illustrative. As you can see, when we ask this specific question, what percentage of residents in your facility have dementia, there's a huge gap in perception between what paraprofessional staff believe and what professional staff believe in both dementia and depression. There was also another question that we asked, which is, do you think it's normal to become depressed as you're getting older and living in a long-term care facility? 76% of paraprofessional staff and 53% of professional staff thought, yes, indeed, it is normal to become depressed as you're getting older and living in long-term care. So when you look at this information about the differences between these two groups, the very high numbers that we're seeing in perception, and how we feel, or majority of us feel, it's normal to become depressed, we can infer a lot of things from these numbers. Perhaps the numbers are illustrating that staff members are missing depression and depressive symptoms because they don't recognize them and are rather seeing the symptoms as dementia. perhaps if we have an assumption that depression is a normal part of aging, we're not seeing the need to identify depression and treat it. We're not recognizing the importance of it. So a lot can be thought of from these numbers, and it's good food for thought. So we're going to take a very quick review before we move into more specifics about the differential between depression and dementia, just to cover the foundation and to use as a point of comparison as Dr. Heck describes this in detail later on in the discussion. Dementia is a term for a group of illnesses or diseases that affect cognition and memory. Alzheimer's disease is the most common form of dementia, 50% of all dementias, and is typically associated with the gradual loss of memory, reasoning, orientation, judgment, along with the progression of a number of behavioral symptoms, including confusion, aggression, agitation. There's two types of Alzheimer's disease that we talk about. Late onset is the most common, the most typical form, and that is when it develops after the age of 65. It is slower progressing. Early onset is the other form that we talk about for folks that are younger than age 65, much faster progressing. The average course is about 60 to 20 years. I did want to emphasize that Alzheimer's is only one form of dementia. There are several other forms that we're not going to cover today. These are some of the classic symptoms of Alzheimer's disease, and I'm not going to go into all of these specifically. I would imagine that most of you are very familiar with a lot of these. We have short-term memory loss, remembering recently learned information, important dates, asking for the same information. We have issues with planning, concentration, seeing a task to completion, makes it hard to follow a recipe or pay bills or remember the rules of the game, misplacing things, may put things in unusual places, go back over steps over and over again. And then when we go down the list, we come into withdrawal from work or social activities, unable to care for self, which affects our ADLs, or activities of daily living, like eating and bathing, and cooking and making meals for ourselves, changes in mood and personality, and losing track of place and time. And I wanted to point out specifically some of the symptoms that are listed at the end of that list, like withdrawal and changes in mood and personality, because as you can see, those are also symptoms that will overlap with depression. In terms of depression, about 10% of hospitalized and 12 to 20% of folks in long-term care will have a full diagnosis. Again, full diagnosis means that it meets the criteria that's outlined in the DSM, or the Diagnostic and Statistical Manual, for a depressive disorder. More folks, as we mentioned before, are going to have clinically significant symptoms of depression within long-term care. And that means that it does not necessarily meet the criteria for long-term care. And then we also have about 10 to 15% of older adults that are in the community have signs and symptoms of depression. Signs and symptoms, for some folks, this could be sadness. For some folks, it's the absence of sadness, withdrawal from activities, sleep difficulties, eating difficulties, lots of different behaviors that may go along with signs and symptoms. The rates of diagnosed major depression in older adults are actually lower than the rates in younger adults. However, we did want to point out that older adults have a greater attempts to completion ratio for suicide than younger adults do. For older adults, it's about 4 to 1 versus younger adults where it's about 30 to 1. And there's, a variety of reasons why these completion rates may be higher for older adults than it is for younger. Perhaps they're more likely to use more lethal means. Perhaps it's due to the inability to recover from failed attempts, either from injury or overdose. Could be several different reasons. Older adults also report that they're most likely to tell their primary care doctors about their emotional difficulties. So the primary care doctors become the front line for diagnosis and treatment within the community setting. But as we know, direct care staff are often the front line for diagnosis in a long-term care, or at least they are part of the care team that helps inform for diagnosis and for treatment. And what's interesting is that mental health professionals are actually the least likely people to hear about emotional difficulties. Older adults are much more likely to tell not only their primary care physician, but clergies and family members. So this also calls for a real team approach to care and to treatment in order to get appropriate diagnosis. And finally, we definitely wanted to make the point that depression can be treated as successfully in older adults as it can be in younger adults. And that is part of the reason why it is so important that we get folks accurately diagnosed so that we could get them into the right treatment to improve their health outcomes. So at this point, I am now going to turn it over to Dr. Heck.
Thank you, Tracy. I do want to apologize to the audience right away because I am just getting over a cold. So I will try to enunciate as clearly as I can. But I wanted to reiterate something that Tracy mentioned, and that is we tend to over-attribute depression to older adults in general. But ironically, we tend to underdiagnose it in a clinical setting. And I think one of the reasons that happens is a function of the diagnostic criteria that we use to diagnose depression. Now, in the DSM, as Tracy mentioned, is the Diagnostic and Statistical Manual of Mental Disorders, or basically the book that gives us the list of signs and symptoms to help diagnose. Depression, according to the DSM-4, are these symptoms that you can see on your screen, these 7 symptoms. And you have to have 5 of these to qualify for a diagnosis of depression. But part of the problem with using these criteria for older adults is that there are numerous reasons why individuals might experience or display these signs and symptoms that have nothing to do with depression. Take sleep disturbance, for instance. One of the things that we know about most older adults is they need less sleep than younger adults, typically about an hour less sleep a night than younger adults need, which is easily mistaken for a sleep disturbance, especially given the fact that older adult sleep patterns are typically spread out more during a 24-hour period as opposed to younger adults who will sleep, for 7-8 hours at a time at night and not during the day. You may see an older adult take, an hour and a half nap, leaving fewer hours at night to sleep. So to the casual observer, they may look like they're having a sleep problem because they're getting to sleep late or they're waking up very early or something like that. It's very easily confused. And that's just one example of diagnostic criterion for depression that sometimes is not very good. And go back up here to significant weight loss or gain, and anybody who has worked with older adults will be able to verify that there are a number of either health conditions or medications or any of the number of other issues that can cause significant weight loss or gain that are not tied to depression. And if you go kind of around and look at these symptoms, many of them aren't exclusive to depression in older adults. Now, one thing I do want to point out up here, the feelings of worthlessness or excessive guilt, that's actually a fairly decent criterion because feelings of worthlessness or guilt are really not normal at any age or in most circumstances. So the presence of worthlessness or guilt actually stands as a decent criterion. If you see that in an older adult, you might start thinking in the direction of, maybe there's a mood disorder. So moving forward, a set of criteria that is probably more useful in picking out depression in older adults is listed up here on your screen. And you look at the top there, you see hypochondriasis, or kind of excessive rumination about health conditions more so than their actual conditions might merit. Actual sleep difficulties, that is after accounting for any age-related changes. Reduced appetite, not just weight gain or weight loss, but reduced appetite in particular seems to be a decent indicator of depression in older adults. Fatigue is also listed. It was listed in the previous criteria as well. It turns out that is, in combination with the other criteria, a decent criterion as well. A lack of positive feelings. That can be distinguished from active negative feelings. You may see a distinct absence of reaction or a distinct absence of emotion. And that is probably going to be more indicative of depression in older adults than, somebody actually walking around saying, they're in a bad mood or showing more obvious signs like that. Apathy, which I think is kind of a companion criterion to the lack of positive feelings. Just the enjoyment and pleasure has been truly removed, and that is after accounting for any physical capability issues that might be there too. And then irritability is pretty big. Irritability tends to be kind of a hallmark symptom of depression in older adults. And I want to emphasize any one of these by themselves does not indicate the presence of depression, nor does their absence indicate the absence of depression. But in combination with one another, you start to get a pretty good picture as to what's going on with an individual. Now, the picture does get a little complicated because what we find is people who have verified depression over the course of their lives, especially poorly managed depression, they tend to develop actual dementia at a rate of 2.5 to 6 times the general population. So if you have depression in your life, you are 2.5 to 6 times more likely to develop an actual dementia process later in life, which tends to underscore the need for treatment and management. And also, complicating the picture, folks who have dementia, 10 to 30% of them also have comorbid depression. So they have both at the same time, which makes teasing them apart very, very difficult. So how do we know if it's depression or dementia? How do we know that? Well, some key observations can help us distinguish between the two. And as Tracy mentioned earlier, it's crucial to tell the difference because we don't want to be treating one expecting to see positive results when we've misdiagnosed it in the first place. These are the areas that we'll want to look at when determining, well, is it depression or is it dementia? We want to look at the symptom development. What do we know about their history? Are they complaining? What are they complaining about? What does their behavior look like? These are all key observations that are not only made by the direct healthcare providers, the licensed providers, but the direct care staff who see them every day, all day. Direct care staff, to no one's surprise, spend more time with individuals within an institutional setting than anybody else. They are a goldmine of information. If A, they know what to look for, and B, we know what to ask them for. So what I want to do now is it's going to feel like a quiz. It's not really a quiz, but it's going to feel a little bit like a quiz because I'm going to give you a couple of signs or symptoms or indicators, and we're going to have some instant polls for you to take. And you tell me whether you think it's depression or dementia. But in this particular case, you've got somebody who has had symptoms that progressed very quickly after they first appeared, and the onset of the symptoms are dated with some accuracy. They know exactly when it started, or the family knows exactly when it started. And then some additional information about this, the family's always been aware of this problem, and they sought medical help very, very shortly after the symptoms began. So what I'm going to do is I'm going to ask you to respond to the poll that Tracy's going to introduce.
Okay, the poll is up right now. So if you could all click, do you think that this is depression or do you think that this is dementia?
All right, and I'm just waiting for any word to go.
Okay. All right, so 87% of our audience think this is depression and 13% think that this might be dementia.
Well, in this particular case, the 87% is correct. It is more likely to be depression. And I'm having a little trouble clicking forward. There we go. It is more likely to be depression. In depression, the symptoms tend to develop pretty quickly. As opposed to dementia, especially Alzheimer's type, where the symptoms are so slow to have their onset that sometimes they're not even noticed for years. And what's really interesting is when you ask somebody, especially a family member, okay, when did it start? They're able to pinpoint it sometimes to the month. They're able to say, you know, it happened about March. If you ask somebody who has Alzheimer's disease, if you ask their family member about when did this have its onset, they may give you an approximate year. They may say, oh, maybe about 2006. So the onset of it can be dated with much more precision when it's depression. The family is very aware of what's going on, and they're seeking help very quickly when they see depression versus dementia, which is much more subtle. So let's do this one more time. And, you know, who are we trying to kid? It's a quiz. I'm not going to lie to you. It's a quiz. We're going to give you nothing here. The individual isn't complaining much about their cognitive problems, and they're actually trying to hide their disability. Does that sound more consistent with depression or dementia to you all? And any complaints about memory or other thinking problems, they tend to be vague and unclear. So kind of log in your answers there, and we'll see what happens.
Okay, 6% of our audience think that this might be depression, and 94% believe this is dementia.
Well, looks like we have a very, very intelligent audience today, because the response that I would go with would be dementia. Those are much more commonly associated with dementia, those symptoms. Folks tend to complain very little about their cognitive loss when they have an actual dementia. And when they complain, which isn't very often, but when they do, the complaints are very vague, something to the order of, you know, I just can't think straight, or, you know, nothing's coming to mind. As opposed to somebody who's depressed, they're pretty vocal about losing their ability to think, and they're able to say exactly what kind of problems. You know, my memory is an issue. I can't remember what I had for breakfast today, or, you know, I can't even remember how to get to my favorite store. And rather than concealing the disability, somebody with depression is much more likely to emphasize it. Kind of a, I don't want to phrase it as a cry for help, but they're not trying to typically cover it up. And at this point, I do want to emphasize, individual presentations are going to be different. There are going to be people that do not follow this rubric, but these are generalities that may help us in terms of observations that we can make. Let's do this again. In terms of behavior, if an individual makes very little effort to perform even simple tasks, and they communicate a strong level of distress, is that more consistent with depression or dementia? So go ahead and log your answers in.
Okay, 93% of the audience feel it is depression, with 7% thinking it is dementia.
Let's see, 7% dementia, 93% depression, you said?
I think so, yes.
Well, it is, in this case, going to be much more consistent with depression. We see very little effort in lots of folks who are experiencing depression, and I don't think that would surprise anybody, and motivation does become an issue. A strong sense of distress, a person is more likely to highlight failures in their life, as opposed to somebody with dementia who's probably more inclined to struggle to perform a task, even if they can't do it. They're not complaining. They seem very unconcerned, especially as the disease progresses. And they tend to delight in what they've accomplished in their life rather than dwelling on the failures. So we've got one more here that we're going to do in terms of behavior. The individual still behaves appropriately in social situations, and the behavioral problems are clearly worse at nighttime. So let's see what you all think.
Okay, 10% believe this is depression, and 90% believe this is dementia.
All right. Well, the answer here is dementia. The loss of social skills happens very early with the onset of depression. And when their mood changes, it's likely to stay changed, as opposed to somebody who has dementia where mood changes tend to go up and down, a lot more so than in depression. And it is not typical in depression in older adults to experience a worsening of depression at night or even in the morning. It's generally pretty steady. If you see a difference, that may point to something that's more consistent with dementia. Excuse me. So what does all of this mean for you all? Well, treatment providers, the people who are actually drawing up treatment plans, prescribing medications, carrying out treatment plans, they're relying on good observations. They're relying on great observations from the people who are spending the most amount of time with the people they're caring for. And sometimes, in a primary care setting, for instance, you only have the observations of the spouse or one son or daughter or the person themselves. But the more observations and the sharper and more focused those observations are, the better. So in an institutional setting, do not leave direct care workers out of the loop in terms of getting their information. We want them to watch the individual's behavior. We want them to actually ask how the individual is doing. I've encountered some direct care folks in my career who are actually hesitant to ask questions like how the person is doing and how they've been feeling because they don't feel qualified to ask those questions. But they are as qualified as anybody to just check in and see how they're doing. And any information is good information. Also listen for increased complaints about health or pain, thinking, anything else. And then look very, very closely how they're eating, how they're sleeping, what their activity level is. And make sure that these observations get to the clinical decision makers for these individuals. Otherwise, decisions will be made, but not based on those frequent and accurate observations that the direct care workers are making. And these observations can very, very easily lead to life-changing treatment for these folks. Depression is very, very treatable. And we're not going to spend a lot of time talking about treatment for depression, but the options that are available to older adults are largely the same that are available for younger adults, provided there are no specific contraindications. But I have a feeling there'll be more questions about that later, so I'm going to actually turn it back over to Tracy for a moment to talk about the survey that y'all took.
Thank you. We wanted to give you the opportunity to look over your responses to the pre-event survey that we had listed up on the website that Nico listed for you. So we have 2 slides that we have attached to this presentation so that you can take a look at what the correct answers to those questions are. And this will obviously also be archived, and I believe Nico said she's going to post it as well so that you can go back and take a look after the presentation is over. And I think we are ready for questions.
Yeah, very good. And I'm going to advance the slide here. Here's our contact information. And as Dr. Welliford mentioned before, folks looking to arrange some form of training, they want to contact Tracy directly to talk about those possibilities. But both of our contact information is there for more specific questions. And with that, we'll close out the formal component of the presentation. I'll turn it back over to our moderator, Dr. Welliford.
Excellent. Thank you for that very informative presentation, Tracy and Dr. Heck. I really appreciate this, and I'm so grateful that you were willing to take this from your live face-to-face training and make it available to a broader audience. I know that what you conducted previously and are still conducting is a statewide training, but this format obviously allows us to reach people in Vermont and Illinois and Maine, and this is very, very exciting to see our returning folks and then some new names on our list, so we're really grateful for that. And obviously, this huge number of attendees is an indication of how important this topic is to folks and how concerned people are about this differential diagnosis issue. And to me, it really brought out, again, the importance of the urgency of changing people's attitudes, because as your case at the very beginning pointed out, it's not just life-changing, it's life-sustaining, and misdiagnosis can be fatal.
Mm-hmm.
And, you know, a lot of folks ask the question about treatment, and I'd like for you to say I'd like for you to not just talk about treatment, but day-to-day intervention.
Mm-hmm.
You know, how you would encourage folks. I like the list of questions that you had people think about, but how would you have people interact with individuals with either dementia or depression on a day-to-day basis? That seems to be a question that's coming from our participants. Can you say a little about that, Andrew?
Sure. Yeah. Well, first of all, I'd like to preface these sorts of answers by saying there's really never a silver bullet.
Mm-hmm.
You know, there is really never, you know, one right thing to say or one thing to avoid saying all the time. But generally speaking, I think anything that promotes engagement, anything that promotes activity is going to be good for an individual experiencing depression or depression and dementia at the same time. Sometimes it's very difficult to engage these folks. They may be very motivated to stay exactly where they are and doing what they're doing.
Mm-hmm.
But encouraging activity is going to add positive benefits in terms of exercising, in terms of increased socialization, in terms of exposure to other activities and things that might pique their interest. So making sure that invitations are always present. You know, hey, Mr. Jones, care to come join us? We're doing this in the event room over here. Or, you know, hey, Mrs. Smith, we're going to have a sing-along by the piano over here. I don't know if you're interested in coming to join us. And you know what? If you have to ask them every hour, go ahead.
Mm-hmm.
I would encourage that. If it looks like somebody's receptive to a conversation about what is bothering them, sit down and have a conversation. A lot of people are, I think, sometimes hesitant, as I mentioned before, to get into it because they don't feel they're qualified. But if you care, you're qualified. And you can actually sit down and say, you know, okay, tell me what's going on. You know, what are you thinking? I'll be a good listener to you. I can hear you. And, you know, I've had problems too. Tell me about them. And if they feel that something is going on that extends beyond them, you know, there's always other professionals they can bring into it and say, you know, he told me something really concerning. You know, I need to pass this on to you as the primary nurse here, or you as the doctor, or whatever. So did that answer your question?
Yeah, it certainly does. And, you know, it also brings up, you know, even more questions. You know me. I love what you've just said in terms of if you care, you're qualified. And one of the points that we really try to bring home with these webinars is the idea of culture change. And in settings where culture change is happening, we know that all levels of care are part of that team. And, you know, I would say if you're present, you're qualified because, you know, the more eyes you can have on residents, the better the care is going to be. And all of those ideas about engagement that you just offered give additional opportunities for assessment.
Mm-hmm.
You know, and the useful criteria that you've mentioned, I think that those are very important. I'm hoping that people, when they have the opportunity to look at the slides after the fact, will share those useful criteria with their teammates and with their colleagues, because those are things that we should all be on the lookout for. Certainly, as you mentioned, feelings of worthlessness and excessive guilt with our older population. And the fact that these can come on so suddenly, you know, that misdiagnosing depression really can be fatal for folks.
It certainly can, and one thing I wanted to add into that too is the idea of recurrent thoughts of death or suicide. And that is something that's also in the DSM that didn't happen to make it onto our slide, but that is a bit of a mixed bag because recurrent thoughts of death, well, as we all get older, thinking about our own potential, well, not potential, actual death, because we're all going to be there.
It's not potential.
It's not potential, right? But you know, thoughts of death are actually not unusual and can be quite healthy in terms of making preparations and finding a place for it. At the same time, though, thoughts of suicide are never ever normal. They're never normal at any point in life. So being able to separate those out and say, okay, well, this person's talking about when they die, they're depressed. No, not necessarily. That could be healthy. But if this person's talking about causing their own death or hastening their own death, that's never normal. And we really have to look into that to see if there's something we should be doing.
Yeah, and I think that carries over to some of the other topics that we've talked about before in terms of end-of-life and end-of-life decision-making, that because our culture is so uncomfortable with conversations about death, I think oftentimes when someone brings up the notion of death, people are more likely to shirk that conversation rather than seeing it as an opportunity for conversation, an opportunity to dig a little deeper, an opportunity to find out, well, is this person doing some planning that we need to have a conversation about, or is it something that is an indication of depression? And you only know those answers if you ask more questions.
That's right.
Yeah.
That's right. And as you talk, more and more things come to mind, and that is, people will ask about assessment instruments, or they'll ask about scales and things like that, and those are fine. Especially if you're looking at large numbers of people in terms of screening. But your best source of information is going to be your direct contact with the individual.
Direct contact.
Direct contact, getting some sort of history. When did this start? What's going on? Talking to people around them. The interview is the most valuable source of information. You can take all the scales that you want out there, and you're only going to get so close to what an actual interview and conversation is going to get for you.
I wanted to mention, just to expand on that a little bit, that I think this leads us to really understand the importance of a team approach to care in terms of staff communication. When we're looking at daily contact with residents, it may be that there's a special relationship that develops between a nurse or a nursing assistant and a particular resident, and they are sharing more of how they are feeling and their emotions with this one particular person that they don't share with some of the other direct care staff. And if staff are not speaking to each other, it's another way that we could potentially be missing some vital information that will, lead to proper diagnosis and treatment for folks. So it's also that staff, I think, need to really have a team approach to the care of the patient and pass along the information to one another when they learn something that could be really vital.
Yeah, I think that's you're absolutely right. That's very essential. One of the questions that's coming up here is you've differentiated between DSM criteria and non-DSM criteria. What led you to, and this is for either one of you, what led you to feel the need to make that differentiation?
Andrew, you want to take that?
Yeah, I think basically trying to rely on the DSM criteria and failing to recognize depression where it actually existed. It's the way that they're set up. It's not geared toward older adults. It's geared toward younger adults, without much mention that it might present differently in this entire sect of the population, and it doesn't even look like in DSM-5, which the revision is coming up probably in the next year or so, that they've accounted for the age difference either. So really trying to use these DSM criteria to diagnose depression and failing, missing it when it's there, and then finding out that there are other indicators that do a better job of picking it out among other possible diagnoses. Does that answer the question?
Yes, it does, and it really points out, I guess one of the primary reasons that you all decided to do this training in the first place is that so many of the issues facing our older population, most healthcare providers have not been trained to address them, and they don't look the same as they do in younger individuals. And so unfortunately, many of our professionals are thrown into settings where they don't have the appropriate tools to deal with them. And how frustrating to have to learn things kind of, in the trenches rather than really walking in the door qualified to feel like you can address the needs of older individuals. So, again, I commend you for being willing to take this training and provide it to a larger audience. Another question that's coming in is about normal grief reaction. And can you say anything about differentiating a normal grief response and how that would look differently than depression? Andrew?
Is that toward me?
Yes, I think so. Yes.
Okay.
Sorry.
Well, you know, and I hate to belabor the obvious, but one thing that we'd want to make sure of is that a normal grief reaction is in response to an identified stimulus.
Mm-hmm.
That is, you know, sometimes you'll find somebody behaving in a certain way, but if you don't know what their history is, you may or may not know that it's in response to something in the environment or something that's happened to you know, cause a loss or something like that. So how to distinguish what is normal in terms of grieving from what becomes problematic, that's very, very controversial.
Mm-hmm.
It's a very, very controversial issue. You know, some people draw the line at 6 months. You know, they'll say, well, you know, grieving happens within 6 months, and if it goes longer than 6 months, it's an abnormal grief reaction. Well, I think we have to be very, very careful with that. There are individual differences, a lot of cultural factors that play into you know, how people express their grief and experience their grief. Now, what is excessive? Because I think what's at the root of this is what would be excessive grief? What would be more than expected? That is a question that's very hard to answer because it depends on a person's baseline. If you're talking about somebody who has depression already, that's going to affect how they grieve. If you're talking about somebody who's never experienced a mood disorder or problem in their life, you know, any indication that they're experiencing some sort of reaction could be problematic depending on how their life is impacted. So I think what I'd have to rely on is look what kind of impact this is having on their life. Has it completely disabled them? Has it completely changed their relationships with people around them? Is there a substance abuse issue that has either begun or worsened? You know, what kind of impact is this having on somebody's life? A normal grief reaction typically, and this isn't by the book, this is more out of experience, but a normal grief reaction will temporarily take somebody out of their routine, and it will temporarily require that their efforts be elsewhere. But it is very temporary, and they're able to resume these things within a short period of time. But if you've got a person who is just continually unable to get back on track, plus these other behaviors like substance abuse or these issues like you know, losing friends, et cetera, that's probably going to be a pretty good start to calling that an abnormal grief reaction.
I think that's very helpful, and it fits in the same, you know, kind of bucket as what you're saying about useful criteria. You know, and if we can encourage people to think about if it's an abrupt change, if it is disruptive, I think that is an excellent rule of thumb in terms of all gerontological practice, that if it's something that's interfering with your day-to-day functioning, then it's pathology. You know, then it is something that you want to attend to, that, you know, that you want to seek treatment for, or seek assessment for it. And again, that's back to changing people's attitudes about aging in general. That so many people think that depression is normal, that cognitive impairment is normal, and we really have to get past that. We really have to, you know, encourage people to think differently. And I think that's true particularly in the long-term care setting, because if that's your lens, if that's where you work every day and that's what you see, then your lens becomes that this is normal aging. And that's not a criticism. You know, I'm grateful for folks who work in acute settings and you know, are in that every day. But at the same time, we don't want to become blinded to what is normal aging and what is pathology, that we need to jump in quickly and you know, have an urgency about changing, have an urgency about addressing. You know, I'm curious, Tracy, if you have some other insights from the research that you've been doing in terms of people's knowledge. I was very curious about how it didn't seem to be about educational level, but about jobs and positions within communities. Can you say a little more about that?
Yeah, I think that is something that emerged that is very curious. to me. And again, I think it really calls for the need for training on the job, because it doesn't appear that it's the type of formal education that somebody has that drives their knowledge. And Dr. Heck and I were actually just having this conversation trying to pick apart exactly what that means. And it could mean a variety of different things. Perhaps it's the type of education, formal education type of degree that somebody comes in with. Maybe there was not a gerontological focus to their training. So even though they may have an advanced degree, it may not be specific knowledge that they need to perform the job as well as they can. But, I'm a glass half full kind of person, so I see this as an opportunity to say, okay, we've done a terrific job in terms of educating folks about dementia and how it presents and what the types are and the stages and the progression, and I think that's fantastic. And I think it's time for us now to expand and to take it in a slightly different direction and say, okay, maybe we need to look at some more mental health issues now in terms of depression or anxiety or mood disorders and the differentiation between all of these. And clearly when you're looking at some of those perceptions, and all of those numbers were very inflated for all different kinds of staff, that also really indicates to me the need for talking about the realities of aging, as you said, and the differences between normal and pathological or expected and typical aging. So, there's work to be done, and there's education that I think will really benefit folks who are working out in the field, either in the community or in long-term care settings, which will obviously then benefit the older adults and their family members. So I hope that this conversation will lead people to want to bring more training in, and to expand their topics to include, some of these attitudinal challenges that we see and perceptual challenges that we see, and expanding the topics to include some more of the mental health disorders that tend to get fuzzy for folks, where they're having trouble picking some of it apart.
Right, and certainly as, we're seeing these demographic growth that, we're anticipating there are going to be more and more people who are hopefully they're diagnosed, but who, have some form of dementia, and being able to pick that apart, like you said, where it becomes fuzzy. Exactly. And I think, some of the questions that people are posting today really go beyond the scope of what we have the time to cover, but it gives me lots of ideas about what our future topics are going to be and how we really do need to focus on picking that apart and making sure people really feel comfortable with the content about dementia and mental health and how everybody can be part of that solution. I really like that, that we don't want people to feel like they're not qualified to ask the right questions, because if you're willing to engage, then you're qualified.
Absolutely.
Okay, so before we wrap up, do either one of you have any, final, very brief closing remarks that you'd like to make, something that that you really feel like you need to add?
I think all I would add is that I want to even overemphasize the idea that our direct care staff play a very key role in managing depression in older adults. In fact, I know I couldn't do my job without them. I count on their observations. I count on their interventions. And the more we can do to equip them to feel more comfortable with what they're doing, the better. And if this type of training helps out, then we should keep doing that.
Yeah. Well, thank you for that. Yeah, I really appreciate that. I'm envisioning my next Facebook post being, "If you care, you're qualified." So I think those really are words to live by. So with that, I'd like to thank you all for attending today's session, and I think we have had a record number of participants today, and I hope that you will all come back on, let's see, is it July 30th for our next session, which is going to be titled Family Quality of Life in Dementia with Dr. Ishan Williams. I hope you'll come back, and I hope you'll bring all your friends. Please take a few minutes to complete the survey that you will receive, and this session will be archived tomorrow, I think. And all of our webinars are up there and available. In fact, some folks posted some questions about medication issues and medication-related problems, and there is a session that is about medication-related problems. I hope you'll check that out. Please make sure that you let us know what your ongoing questions are, because we will create webinars based on your questions. That's how this works. I'd like to again thank our sponsor today, Commonwealth Retirement Advisors, for not just their sponsorship, but the work that they do with their holistic approach to financial planning and integrating gerontological knowledge in the work that they do, and also the support of the Virginia Center on Aging GTE grant. And again, thank you, Andrew and Tracy, for being with us today and reconfiguring what you've done so we could offer it to a broader audience.
Our pleasure. Thanks for having us.
All right. Everybody have a great day, and I hope that you've learned something today that can be useful to you and you will be able to put it into practice immediately.